Thank you. Yeah, Sami, excellent. That is, you don't see this very often. It's a case of methemoglobinemia. Very well done. Can anyone, I think three people have answered. Excellent, fantastic. I'm very happy. Can someone explain to me, or you can unmute and answer to the wider audience, why do you get, saturations on the pulse oximeter look better, but child appears quite blue? What could be the reason? Please feel free to unmute and answer. Okay, so basically, I think the usual pulse oximeter normally it takes into account the oxyhemoglobin versus deoxyhemoglobin. It matches in those two ranges. Whereas methemoglobinemia, because of what it is, the pulse oximeter standard one, it doesn't differentiate between methemoglobinemia and oxyhemoglobinemia. So that's why you get disproportionately higher percentage of saturations. So beware when you see a pulse oximeter reading falsely high, but the child is looking blue. What would be the treatment of choice? What are the possibilities? You can use vitamin C or methylene blue, depending on how severe the condition is. Okay, so the key learning point from here is not all blue babies have a congenital heart disease. Okay, so that would be the first take on. Now, regarding congenital heart disease, there are different modes of presentation. For example, day of onset, they can have different symptoms or signs. For example, can someone think of congenital heart disease presenting on day 1 of life? Any answers? Anyone? TGA, yes, TGA can present. Excellent. All right, so a lot of answers, TGA, excellent. Regarding symptoms, they can be blue, they can be breathless. We will go through some of the cases. Regarding signs, remember, apart from cyanosis, there may not be much in many cases. Sometimes they may or even may not have a cardiac murmur. When you assess a child with possible heart disease, it is important to go through in a systematic manner. So first of all, check pulses, simultaneously go for brachial and femoral pulses. That will give you any discrepancy. Forelimb blood pressure, it is always useful, pre and post ductal. Again, pre and post ductal saturations, quite commonly used when you see a blue baby. We'll go through that again in the next couple of slides. Always understand how a normal ECG can look like. Okay, you should be able to look at the rhythm, the axis, the rate. Are there any signs of ischemia? So those of you, a useful learning exercise would be understand a normal neonatal ECG. Okay, then chest X-ray. There can be a variety of findings: pulmonary plethora or oligemia, cardiomegaly, or normal heart. Then a lot is said about hyperoxia test, so we'll come to that. So hyperoxia test, most often it's not done these days. What it means is when we give 100% oxygen to a baby for around 10 minutes, then you do an arterial blood gas. Then if the PaO2 is more than 34, you can exclude cyanotic congenital heart disease. But that needs an arterial stab, which is not practical. And also, if PaO2 does not increase significantly, the child can still have a heart disease or a lung disease, so it doesn't tell you a lot. Okay, so hyperoxia test is probably best avoided. So moving on to differential cyanosis. So if you look at this picture, you can see the ascending aorta, you can see the pulmonary artery, you can see the duct, and then there is a right to left shunting. It is much better to say pulmonary to systemic shunt, which you can see with clearly marked by the arrow. The conditions giving rise to this differential cyanosis, uh, persistent pulmonary hypertension or coarctation of aorta. So there you will have pulmonary to systemic shunt. And why are we interested in knowing pre versus post? In this example, you can see the ascending aorta and the first two branches are red and the descending aorta is blue. Remember, the carotid arteries that are coming from arch of aorta, they supply the brain. That is why preductal saturations is usually more important when you are managing a blue baby. Now, if you look at the next picture, so here you have a baby with TGA with low pulmonary vascular resistance. So whether it is during systole or during diastole, you have systemic to pulmonary shunt. Okay, so in this case, whether it's a preductal or postductal, the saturations will be equal. Now, in case of TGA with pulmonary hypertension or coarctation of aorta, remember, this is TGA, that's why your pulmonary artery is marked red. And because of pulmonary hypertension, the blood preferentially goes through the duct into the descending aorta. So your preductal saturations will be lower than the postductal saturation. This is called reverse differential cyanosis. So chest X-ray patterns, you can have, as I said, a normal size heart, or you can have a cardiomegaly. Can someone give a couple of differential diagnoses for a blue baby with a normal size heart that is you're seeing on the left-hand side of your chest, on your screen? What do you see? It's a normal size heart with nearly white out lungs. So what are the possibilities? Anyone? TGA, maybe, but this child is actually quite unwell, just born patient or a neonate. TGA usually will not give you this type of pulmonary edema. Someone said PPHN could be, yeah. PPHN is a possibility. Any other thoughts? Tetralogy of Fallot usually is a reduced pulmonary circulation. So here what we are finding is lungs are quite wet or there's pulmonary edema. So unlikely, yeah, TAPVC, yes. Within that you have obstructed infracardiac TAPVC. So if you see a neonate with whiteout lung fields and a normal sized heart, and the baby is in a very low cardiac output state, think of obstructed infracardiac TAPVC. There are other kinds of TAPVC like supracardiac or intracardiac. They do not necessarily present on day one with a collapse. Okay, so the answer to the first one is PPHN. Yes, it could be sepsis, or it could be infracardiac TAPVC. And we'll come to the cardiomegaly as we go along. So here is your case 2. A 6-hour-old male neonate, full-term normal delivery, no risk factors for sepsis, mild tachypnea, otherwise well, SATs 86% in air. Okay, so the baby is otherwise well, but a bit cyanotic. So this is a chest X-ray, and that's the ECG. So what do you see on the chest X-ray? It's cardiomegaly. Okay. So my question is, what are the differential diagnoses for a neonate with a large heart? One is Epstein's anomaly, Epstein's. Second one, excellent, fantastic. So so far I have received 3 responses, all saying Epstein's, excellent. This could be Epstein. What are the other causes of, yeah, cardiomyopathy? Absolutely. Any other differential diagnosis? Pulmonary atresia may or may not. I mean, this is a massive cardiomegaly. TAPVC usually doesn't come with this large heart at birth. Okay. Pericardial effusion, absolutely. Neonatal hydrops or pericardial effusion. Yeah, very right. Hypoplastic left heart can come with massive cardiomegaly. Yeah, so I think these are common causes of neonatal cardiomegaly. And what do you see on the ECG? Can somebody highlight 1 or 2 features that go more in favor of Epstein's anomaly? What do you see? What do you see where my arrow is? Tall P waves, excellent. Okay, that's fine. I mean, right atrial enlargement, excellent. Well done. Right atrial enlargement is the correct, or the most sophisticated answer. This is just to give you, may not be necessarily associated with this patient. What do you see here? The new ECG. Sometimes Epstein's can present with some arrhythmias. I'm giving you a clue. Excellent. Delta wave, shortened PR interval, so they can present with STV. Fantastic. So Epstein's can present with cardiomegaly, right atrial enlargement. They can have SVT as a presentation, and this is a classic delta wave. Well done. So this is a normal heart, and this is a Epstein's heart, just to give you a perspective of how cardiomegaly looks like. And this is an echo picture. This is the left atrium, left ventricle. This is the right atrium. This is the atrialized right ventricle. The actual right ventricular cavity is here, tiny, tiny. So this whole thing is enlarged or massive right atrium. Okay. So moving on to case 3, we have a 16-year-old male infant, term, normal vaginal delivery, no risk factor for sepsis, child is on postnatal ward, grunting, cyanosed, SATs 60% in the air, brought into NICU, intubated and ventilated, IV access, fluid given. SATs are 80 now on 100% oxygen. Chest X-ray is unremarkable. I'm giving you the ventilation settings, 28/6, rate of 35, I time of 0.6, and this is the arterial blood gas. Okay. Now, these are all real cases. So we got this call from DGH, and so the question was whether it is cardiac or whether it is, say, for example, PPHN. If it was PPHN, perhaps better to refer to an ECMO center. This was long time ago. Or if it was TGA, perhaps Brompton could accept this patient. We had 1 bed. So any clue you can find on this slide that will make you think whether it is PPHN or a TGA. Lactate can be increased in both. Someone said lactate. Even PPHN with low output, they can have high lactate. It is not that specific. I'm asking a broad clue. Respiratory distress, grunting, TGA, usually no respiratory distress. Yeah, if you have a TGA who is otherwise stable, then there may not be any respiratory distress, but you can have TGA who can go horribly wrong in the very early hours. Someone is commenting on PaO2 despite FiO2 1. Again, this can happen with both. Someone is saying ventilatory settings, FiO2 requirements. Persistent hypoxemia. Yeah, I'm looking for one more clue. I mean, so far, I think these two, all the suggested answers can go either way. If you have seen a sick TGA, everything else is compatible. There is some clue in the ventilatory settings. Excellent, Sarah. CO2. See, CO2 is a clue here, all right? So just to explain this, in PPHN, the actual blood flowing into the lungs is quite less, okay, if it's that severe, and the saturations are low because deoxygenated blood is going through the duct and it is going into the systemic circulation. That's why you get hypoxemia. When the CO2 on the blood gas is low, what it means is there is good gas exchange happening in the lung. That means the blood flow to the lung is adequate. So this can happen in TGA, but usually not in PPHN. PPHN, the blood is shunting via the duct, pulmonary artery, duct, descending aorta. Okay, so CO2 is a clue here. And we took this baby and it turned out to be TGA. Of course, this is not 100% specific, but this will explain the pathophysiology behind the CO2 exchange. So the initial steps when you see a blue baby, always start Prostin, start the referral process. Okay, monitor pre and post ductal saturations. We'll come to that, and confirm the diagnosis if possible. These days, a lot of hospitals have pediatricians with special interest in cardiology. They can do a quick bedside echo. This will also help, triage. For example, sometimes there may not be any need to transfer the patients urgently, or in some patients, you need a rapid transfer. And also, this is very important. Remember, when you are dealing with a TGA circulation, the blood, venous blood, is coming to the right heart. So whenever you are trying to put an IV cannula, if there is any air bubble, this will straight away go into right heart, and then directly, you can have embolism, stroke. Okay, this usually doesn't happen in a normal circulation, but in a TGA, be very, very careful. So the treatment of choice when you see a new, blue baby, both dinoproston and alprostadil, that is PGE2 and PGE1, both have similar kind of action, mechanism of action and side effects. But just to minimize the confusion, I think the current recommendation is Prostin, that is PGE2, is the treatment of choice. Some centers might use alprostadil, but both are similar. Okay. Please do not confuse this with prostacyclin or epoprostinol. They are mainly pulmonary vasodilators used in pulmonary hypertension. Okay. So there are some practical considerations when we are dealing with Prostin. The first thing is access. Okay. So how many venous lines would you need when you start Prostin, and why? Okay, so yeah, the right answer is 2 in case one fails. Tom says 2 as short half-life. Excellent answer, because Prostin has a very short half-life. It's around 3 to 4 minutes. Okay, so if you are trying to run with only one axis and if you lose it, then it may be quite difficult, especially in a retrieval scenario. Okay, so the key point is Prostin's half-life is very short, 3 to 4 minutes. Okay, dose range in a stable patient, you can sometimes you have TGA antenatally diagnosed, child is otherwise stable. You can start at 5. Sometimes if you have a sick patient who is lactate is rising, you had to tube, you had to resuscitate, then 10 to 20 is a reasonable starting dose. Regarding maintenance, remember, when you start Prostin, we can't just start Prostin and then move away and to look after other patients, because as we said, you need to monitor the effect of Prostin. Okay, so when you're starting Prostin, say saturations are 60%, you have started at say 10 nanogram per kilo per minute, you would wait for 10 to 15 minutes to see a response. If the response is not adequate, then you need to increase the Prostin dose. Okay, so you need to constantly titrate to the effect. Regarding the infusion rate, because the dose is so small, please remember when you connect it to the IV cannula, it may take a while before it hits the circulation. So sometimes do not expect rapid improvement within few minutes. Okay, it may be sometimes even better to flush the IV cannula with Prostin, things like that, in a very sick patient. So remember the dead space in the IV cannula. I think you should consider that. Then monitoring the side effects or monitoring the effect. I would go for effect more than side effect, because you wouldn't hesitate to increase the Prostin as required. Beyond 15 to 20 nanogram per kilo per minute, risk of apnea is quite high, but then you would treat it with intubation and ventilation. Sometimes in emergency, you can use oral route Prostin. This is 30 to 60 microgram per kilo. But this is not the first choice. Okay, this is just to make you alert that occasionally we do use Prostin orally. Okay, this is just so you know it. All right. Lack of response. You have started Prostin, you have a blue baby, you still don't know the diagnosis yet. You have started Prostin and the child is not getting better. Any clues? Yeah, it could be other cardiac, it could be a wrong diagnosis. Okay. Remember, as I said before, all blue babies are not cardiac. Make sure the IV access is okay, there is no extravasation, and make sure you're not missing any other diagnosis. This time I will give you a simple scenario. You have a prenatal diagnosis, just born female neonate, antenatal diagnosis of tetralogy of Fallot, subvalvular infundibular pulmonary stenosis, 8 millimeter perimembranous VSD, and good size branch pulmonary arteries. Child is centrally cyanosed, warm, well perfused. All pulses are well felt. 3/6 ejection systolic murmur. SATs are 82% in air. What would you do? Any thoughts? Would like to know severity of PS. Yeah, I would say, the gradient is, say, let's say 60 millimeters of mercury. I mean, just to put it in a normal way, this is a standard tetralogy of Fallot. It is not extremely severe. SATs are 82% in air. Nothing. Excellent. Nothing is a good answer. You don't need to start Prostin here, because this is a tetralogy of Fallot. You need to expect SATs in the 80s. This is given as it is. It won't be a duct-dependent lesion for now. Okay. Sometimes, if you don't know the diagnosis, fair enough. Okay. Prophylactic propranolol, not straight away. Propranolol usually, if there is a history of a spell or things like that, I wouldn't say we start propranolol automatically unless the heart rate is too high or things like that. All I'm trying to say is this is the standard tetralogy of Fallot, balanced, good hemodynamics. So do nothing. This child will need follow-up with cardiology team. So the point is, when we are talking about blue babies, there are two things. One is every lesion has a spectrum, and then you also, that comes with a target SpO2 that we need to understand. For example, as we just discussed, a balanced tetralogy of Fallot that's in the high 70s, mid 80s is within normal limits. Sometimes you can have pink tetralogy of Fallot. That means the infundibular stenosis is not that tight and it behaves more of a VSD. So the saturations may be quite high. Then you may also have, okay, how do you know if it is balanced? Okay, so if the saturations are in the 80s and the echo diagnosis reveals no surprises, I'll come to that, then it would be a balanced tetralogy of Fallot. If the same patient has saturations in the 60s, then it may mean that the infundibular stenosis is extremely tight, or there can be multi-level pulmonary stenosis. Okay, so there the saturations will be quite low. There probably I would start Prostin. Okay, will that be shown antenatally? Yes, antenatal diagnosis is quite accurate, but the saturations give you much better understanding. And also remember, things can evolve during pregnancy. So sometimes antenatal scans, they can progress. All right. So what I'm trying to say is, if an antenatally diagnosed standard tetralogy is born and the child has saturations in the mid 80s, then I would reasonably confident to say that it will be a balanced tetralogy. You can have, as I said, a blue TOF where the infundibular stenosis is very tight, or it can have pink TOF. Okay, the same applies to TGA with intact ventricular septum. This we call it as simple TGA. SATs in the 70s to 80s is perfectly acceptable. TGA with VSD, they can have high saturations. Okay, you would be surprised. We have seen TGA with VSD and a duct with a low pulmonary vascular resistance saturating 99 to 100%. Okay, so absolutely at birth you will not be able to clinically diagnose that. Epstein's again varies, 70s to 90s. Hypoplastic left heart, 70s to 80s is usually considered acceptable. Again, remember, it depends a lot on morphology as well as pulmonary vascular resistance and whether the child is on oxygen and Prostin. Why it is important to understand the target saturations is how do we use oxygen in these babies. Say if a tetralogy is saturating in the 80s, there is no need to give supplemental oxygen. Or for example, if a child is born with hypoplastic left heart, if the saturations is around 75% in air, please do not give additional oxygen because it will tilt the balance and the child will end up in low cardiac output state. So it is very important to understand the target saturation and the underlying pathology. So the key learning points. So not all babies with congenital heart disease need immediate treatment. We need to understand target saturations. Any unwell blue baby, think of heart, Prostin. Once you start Prostin, please titrate to effect and then organize a transfer. As pediatricians, never ever forget sepsis. I think early antibiotics is always the best way to go. Because this is a neonatal week, so we got to briefly touch upon some of the changes that happen at birth. Fetal circulation is usually, shunt dependent parallel circulation. Okay, and there are rapid and significant changes that happen at birth, and the drop in pulmonary vascular resistance is mainly due to increase in PaO2. So if you look at this picture, the fetal circulation is dependent on three shunts. One is the ductus arteriosus, the second one is foramen ovale, and the third one is ductus venosus. So when a baby is born, first of all, with rapid, when the baby cries and the blood starts shunting from aorta into pulmonary artery, because the pulmonary vascular resistance drops dramatically, the pulmonary blood flow will increase at least 8 to 10 times. So on one hand, you got reduced pulmonary vascular resistance, which will lead to high pulmonary flow, which will in turn lead to a lot of blood coming back into the left atrium. Now, on the other side, the placenta is out of equation now. Once the placenta is out of equation, the peripheral vascular resistance increases. So again, that puts the pressure on the left heart up. Okay, in other words, the left heart pressures go up soon after birth. Once also the placenta comes out of equation, plenty of blood that was going via ductus venosus into the right atrium, that amount of blood comes down. So the pressure in the right heart decreases. So these changes will lead to increased left atrial pressure, decreased right atrial pressure, and then the foramen ovale closes. And as the PVR goes down, PaO2 increases, the duct starts to close. And as the blood flow from the placenta is decreasing, now the ductus venosus will also close down. So these are the few changes that happen soon after birth. Within 48 hours, functionally, all these three should be down, all three communications. And that leads to PPHN. I won't go into too much of detail because I think it will be covered in other neonatal topics. So PPHN may be primary or secondary. In very simple terms, primary is usually idiopathic. There is no obvious underlying cause, whereas secondary could be due to sepsis or meconium aspiration. You can see a lot of changes in the lungs. Okay. Presentation, I won't go into too much of detail. They can present in a variety of scenarios. Echo is important to rule out congenital heart disease. Look at tricuspid regurgitation with estimated RV pressures, right atrial enlargement. Sometimes it's useful to get an idea how the ventricular function is, and also the ductal shunting, pulmonary to systemic. Very broadly, the treatment strategy for PPHN, maintain adequate systemic blood pressure using inotropes, sometimes vasopressors, decrease pulmonary vascular resistance, and ensure oxygen delivery to tissues. So that is increasing cardiac output. While we do all of this, I think the key thing is minimize the side effects of what we are doing. Remember, when you use high FiO2, it comes with its toxicity. And also when we are on high ventilatory pressure settings, that can also damage lungs. Okay, so the whole ethos of PPHN management is minimizing the toxicity while accepting saturations in the high 80s. Do not aim for 95 or 100. The ventilation strategies always start with the airway. Make sure the ET tube is in right position. Sometimes if it is too low, it can cause significant problems. Make sure there are no pneumothoraces. Now comes a couple of key points regarding PPHN management. pH, it is important to avoid or treat acidosis. In other words, aim for normal pH. Okay, you do not need to go for alkaline pH. Alkaline pH, you only do it in a pulmonary hypertension crisis scenario. Okay, so I would aim for normal pH and normal CO2. Again, avoid hypocapnia because you are compromising cerebral circulation. Okay, so normocapnia and normal pH. The child will need adequate sedation plus minus paralysis. Again, bicarbonate or THAM can be used. Some people probably use excessive bicarb, but please go for just a normal pH. Okay, so there are a couple of questions. Let me have a quick look. Choice of inotrope for PPHN. How do you know if to give fluid or increase inotrope rate? I thought for PPHN, they always aim for higher SATs than 80s. Yeah, I wouldn't say 81 or 82. If I can get saturations, say for example, 88 or 90 with 60% FiO2, I would be more happy with that. Whereas if I'm getting 91 with 100% FiO2, I'm not sure what added advantage. Probably there is more disadvantage in using FiO2 of 100%. So it's a balance. I wouldn't say high 90s, but 88 to 90, 92, depending on how much FiO2 you are using. You need to balance that. But you don't necessarily need 95 to 98 saturations whilst on, say, 90% or 100% oxygen. Okay, you need to balance it with how much oxygen you are giving. Happy with using SpO2 or need to use PaO2? I would be happy with SpO2. PaO2 to guide ventilation. We will come to that in a moment. I think the use of blood gas probably it can be minimized. Okay, if you do not have an arterial line, because these days we have end-tidal CO2 to monitor CO2 levels. But again, remember, when you're dealing with PPHN, the blood flow to the lungs is quite limited. So EtCO2 may not reflect the arterial CO2. As far as saturations are concerned, I think over the next couple of slides, probably I'll be able to explain better. Someone else is asking, I thought for PPHN they always, okay, that's answered. Choice of inotrope. In the past, I think people used to start with dopamine, then dobutamine. Then when the child becomes sick, you start with adrenaline and then go to noradrenaline, then retrieval, and then transfer to a tertiary center or an ECMO center. If the child is very sick and you are struggling with blood pressure, you can start with peripheral low dose adrenaline. Okay, adrenaline doesn't have to be given centrally. I would like to highlight the current recommendations, both whether it is STRS or CATS. You can use low dose adrenaline peripherally, but there is no harm in using dopamine to start with. But I'm just making a point that please don't assume if you want to use adrenaline, it has to be a central line. It can be used peripherally. Sometimes we can use a vasoconstrictor to raise systemic blood pressure, which I think, yeah. So regarding circulation, in a neonate, it's very hard to assess clinically whether the child will need volume, but there's no harm in starting with 5 to 10 mils per kilo of volume and see what happens to the saturations, okay, or even the cardiac output. It would be very tricky. Sometimes you can take help of ultrasound, but I think it needs a little bit more expertise. I wouldn't worry too much whether we are giving extra fluid or not. 5 to 10 mils or 15 to 20 mils to start with. You can start with the volume resuscitation while preparing for subsequent inotropes and vasoconstrictors. Remember, without enough volume, inotropes will not work. So as I was describing, systemic pressures need to be more than pulmonary pressures. That means using some vasoconstrictors, you might reverse the shunt across the duct. And once you break that cycle, once you convert a right to left shunt into left to right shunt, your blood going into the lungs has more PaO2 that will further reduce your PVR. Okay, so there is no standard algorithm for which type of inotropes, but it is reasonable to start with dopamine or adrenaline, and you can add a vasoconstrictor, for example, noradrenaline. In a cardiac unit, this is just so you are aware, vasopressin has very little effect on pulmonary vascular resistance. So that is increasingly becoming our drug of choice, whereas sometimes noradrenaline can still act on your PVR. So between noradrenaline and vasopressin, personally, in a cardiac ICU, we go for vasopressin. Milrinone, be very cautious, because if you're dealing with a situation where the blood pressure is already low, milrinone can cause further hypotension. Milrinone is best used when you have reached a stability, like you are on some inotropes, you have given some volume, child is stable on the ventilator, you have reached a steady state, then very cautiously you can introduce milrinone. Milrinone's main side effect would be hypotension, so be very cautious about that. So a couple of questions. Are you focused on mean blood pressure or systolic blood pressure? I mean, mean blood pressure should be fine. We don't, some people tend to use one over the other. If you are constantly monitoring the situation, you can choose to use, systolic blood pressure itself. That should be okay. If you raise the systolic blood pressure, the mean blood pressure will also go up. Okay, they go hand in hand. But choose either one. But I think what is more important is, constant monitoring when you're on inotropes or vasoconstrictors. Okay. Yeah. So, for example, in a neonate with the PPHN scenario, we would probably see mean blood pressure somewhere between 50 and 55. Although the normal is 40, but because we are in a PPHN scenario, you may want around 50 of mean blood pressure. Okay, this is a rough guide. It is very hard to titrate or give an exact number, but around 50 where probably I would go for. Another question. Okay, no. So there are pulmonary vasodilators. They work in different pathways. For the purpose of this talk, I think we can focus on the drugs which use on cyclic GMP pathway, that is nitric oxide or sildenafil. They can both be used in acute scenario. Even prostacyclin can be used, but it is usually used in an ICU setting. So inhaled nitric oxide usually started when oxygenation index is more than 15. OI is basically how much pressure and oxygen you are giving and how much PaO2 you are getting out of it. So that summarizes the concept of oxygenation index. When you're on nitric oxide, you need to monitor methemoglobin levels. Usually the dose is between 5 and 20 parts per million. But those of you who are interested in pulmonary vascular resistance or nitric oxide, remember, even 5 is a good dose. The actual dose where it works is between 1 and 2. Anything above is, sometimes we are just used to it. You don't need 20 ppm all the time. Okay. And again, weaning strategies, again, it will take some time, but if you have any questions, I'm happy to answer. In retrieval scenarios, we have used magnesium sulfate. It's a potent vasodilator. Be careful. So it can help if you are struggling to bring down the pulmonary pressures. Also remember, maintain normothermia, because a cold baby, temperature is not helpful if the PVR is too high. So traditionally, we have been taught, okay, if oxygenation index is more than 40, consider ECMO. But remember, OI more than 40, the mortality is up to 80%. And also, if OI is more than 25 over many hours, there is increased mortality at all ages. So the point is early referral. So if you are struggling on nitric oxide and your OI is hitting 25 or 30, start talking to an ECMO center. It doesn't mean that the child needs ECMO, but the child is better managed if you hit that level. Okay, so early referral is the key. There are limitations of OI in neonates. First of all, it is invasive. It requires arterial blood gas, and you can only do it intermittently. And also, whether the arterial blood gas is pre or post ductal, because if there is a shunting across the duct, if you do a post ductal gas, your PaO2 may be low. And also, in neonates especially, OI, we don't know whether it is a result of severe lung disease or simply it is pulmonary vascular resistance and the blood is shunting from pulmonary to systemic. So I would caution you using OI as an indicator. Okay, in an older child, when there is no duct and there is child is in ARDS, you can use OI. It is much better than PaO2 FiO2 ratio. But in neonates, it has its limitations. Do a cranial ultrasound scan if the child is very sick, especially if you need ECMO. Just to show you, this is Prof. Bartlett. He's a surgeon from Michigan. He put this baby with meconium aspiration syndrome in 1972, Esperanza. She's now 47-year-old. She's alive and well. So this is your first ECMO baby in neonate. So over last many years, the number of ECMOs in neonates have consistently come down. This is a reflection of better intensive care management, lung protective strategies, use of judicious use of oxygen, as well as overall management and understanding of the disease. So this is actually a tribute to a better neonatal intensive care in recent days. There are some criteria for ECMO consideration. These are all self-explanatory. The key thing I would like to highlight, the one is gestational age, 34 weeks, and failure of maximal medical therapy. First of all, you should not reach this stage, failure of maximal medical therapy. I think by that time, you have damaged the lungs. And what about gestational age? So if you look at this graph, beyond 34 weeks, the risk of intracranial hemorrhage goes down significantly. Okay, so that's why earlier than 34 weeks, the risk of IC bleed is too high. So we wouldn't consider automatically for ECMO. So if you look at this graph, all I'm trying to impress upon you is the survival when a neonate with PPHN goes on ECMO is actually 83%. Okay, of course, the survival to discharge is close to 70%. Remember, these are not well babies going on to ECMO. These are extremely unwell. They are on huge amount of ventilation plus inotropes, and at that level, when they go on ECMO, they up to 70% of them they make it to discharge. So ECMO is a standard of care in a very sick neonate with PPHN. Okay, this is one of the best cohorts where you should consider ECMO early, not too late. So key learning points: understand transitional circulation. When you're managing a patient with PPHN, protect the lungs and brain, and early ECMO referral. So this would be the last case. So you got a term baby, day one. SATs are in the 70s. There is a history of NSAID during pregnancy. This is the ECG. Any thoughts? Okay. So basically, what you're seeing is right axis deviation. If you look at the AVL, there is extreme negative deflection. Um, so basically, this is suggestive of a right ventricular hypertrophy, but it's not that unusual in a neonate. This is the antenatal scan. What can you see in the antenatal scan? If you look at this echo picture, any volunteers? Excellent. So very thick RV muscle. Absolutely. Thick and right RV hypertrophy. Fantastic. So you got a baby whose SATs are in the 70s, and you got an extremely thick hypertrophied right ventricle. What are the possibilities? Obviously, with this, what happens is there will be shunting across even the ASD. There could be right to left shunting that will give you some cyanosis. Any possible diagnosis? Pulmonary atresia, critical PS, excellent. And you do an echo, you continue, there is no right ventricular outflow tract obstruction. There is no pulmonary valve stenosis. Yeah, there may be or may not be, but yeah, you would. This is a reasonable differential diagnosis. History of NSAIDs. Uh, I mean, this is just a small clue. So sometimes you can encounter this. It's not a very common condition. So this is premature fetal closure of arterial duct. So basically, if you understand the pathophysiology during the fetal life, the right ventricle ejects around 2/3 of combined cardiac output, and 90% of that is shunted via the duct to the aorta. So if you look at this picture, so this is the ductus arteriosus, this is the pulmonary artery, these are branch pulmonary arteries, duct, and then this will go into the descending aorta. Now, if the duct closes prematurely, which can happen with NSAIDs during pregnancy, what happens is there is no outlet for the RV. So this results in very muscularized pulmonary artery. There can be pulmonary regurgitation. You can have a mixture of pulmonary stenosis and pulmonary regurgitation, or there can be massively enlarged branch pulmonary artery as well as main pulmonary artery. This group may present with airway compression. Okay, so this is an uncommon condition, but just keep that in mind. So clinical outcomes can range from antenatal hydrops to even neonatal death, but majority they require observation and oxygen supplementation. Some of them might need ventilation or pulmonary vasodilators. A tiny minority might require ECMO support. If this is diagnosed antenatally, towards the end of pregnancy, you can consider premature induction of delivery. So just to summarize, understand the transitional circulation. Blue baby is not always cardiac, but always consider Prostin. Do not shy away from administering oxygen when on Prostin. You can give as much oxygen as you like. Don't worry that the duct might close. If you're on Prostin, feel free to give oxygen. Also understand the target oxygen saturations. Systematic approach to blue baby, clinical examination, investigations, early referral. getting some couple of comments. No point in Prostin in that previous clinical example, premature ductal closure. It is worth starting Prostin. It does no harm. When we say premature ductal closure, sometimes it may be almost closed. So in that case, if you use Prostin high dose, it might help. Sometimes you do start Prostin, you do the echo, and there is absolutely no flow at all. Then you might decide to discontinue. But I completely agree with you. Start Prostin. It does no harm until you monitor the effects. And finally, in the PPHN, the key principles are minimize oxygen toxicity, minimize ventilation-induced lung injury. Don't start using peak pressures like 30, 32, or 35. FiO2 of 100. Probably that is too late. And always consider early ECMO referral. It doesn't mean the child will end up on ECMO, but start talking early rather than when it is too late. Thank you very much for listening. Any questions? Okay, thank you very much. Thank you. How do you use or interpret SVO2? Okay, so a quick answer. SVO2, that is a mixed venous saturation, you can use. It's very uncommon in neonate unless you have a neckline. You need a jugular line. You can't really interpret much if you have a femoral. Subclavian or jugular you can interpret. Always take into consideration the arterial saturation and the venous saturation. If the arterial saturations are, say, 85, your mixed venous, if it is in the 60s, then you have adequate cardiac output. If the AV difference is more than 30 to 40, then that's an early sign of low cardiac output state. I hope I've answered the SVO2 question. More surrogate marker is using a NIAS, near infrared spectroscopy. It will give you a decent surrogate marker. True mixed venous saturation is quite difficult unless you have a neckline. Thank you very much, Natasha. So one question is, while in tricuspid atresia with VSD, we have to start Prostin. Okay, so as I said, it's a spectrum. If it's a tricuspid atresia VSD, but there is no right ventricular outflow tract obstruction, you don't need Prostin. Okay, so it's important to understand the full spectrum of the disease. If it is TA, VSD, but with PS, then you may need. If there is no pulmonary stenosis, you don't need Prostin. Thank you very much, guys. I'll wait for a minute or so. If anyone has any questions, please feel free. Otherwise, after a minute or so, then we can say goodbye. Thank you. Okay. Thank you very much then. Have a nice evening and have a nice weekend. Thank you very much. Bye-bye.